we upload our webinar to our YouTube page, and we actually send out a recording of that as well as the link directly into YouTube, and we send that out via email. And so if you are one of those who's interested in seeing this presentation again or sharing it with family or friends for the type of impactful content you'll be hearing today, you can look for that email. We'll have that email captured, as that's how you were able to register for the webinar this afternoon. From there, and without further ado, now that I've done all of my webinar need-to-knows, I'm going to turn it over to Dr. Dunsmore Sue, Dr. Dooley, and Dr. Savage. Thank you all. Take care.
All right. Thank you so much, Tyler. Hi, everybody. I'm Dr. Rebecca Dunsmore Sue. I'm the Chief Medical Officer here at Genève. And I have a couple of things that I want to discuss with these lovely physicians who are joining me on the webinar. And then we're going to make sure to leave plenty of time for Q&A at the end. I do want to just mention that when we answer questions, we can't give direct medical advice via a webinar. But if you ask something that seems a little personal, we might answer in a more general way about how we generally handle something. But you're always welcome to come see us at Genève if you want to ask us personal questions and get actual medical care from us. So, like I said, Dr. Rebecca Dunsmore Sue. I'm a board-certified OBGYN. I've specialized in menopause for the last 10 years. I am Menopause Society certified practitioner. And my journey to menopause care was sort of circuitous, as many are. But before I go into that, I'm going to give you one fun fact about myself and then ask the other doctors to do the same, just so you can get to know us. So my fun fact is that I am a serious gardener, hobby farmer. I love to grow vegetables of all sorts. I have chickens, and just love sticking my hands in the dirt. It makes me feel grounded. So, Dr. Dooley, I'm going to call on you next. Can you introduce yourself and give us a fun fact about yourself? Oh, there you are.
Yeah. My name is Jessica Dooley. I am also board-certified OBGYN, and I was fellowship trained in urogynecology. So I have been working with perimenopausal and menopausal women the entire course of my career, started in 2017. And I actually, fun fact, let's see. Fun fact is that I really want to learn how to ski or in particular snowboard, but I have in both of my 2022, had to have surgery both times. So that's the thing. I may try one more time. We'll see.
So Shika, whenever you turn your head to one side, we can't hear you. So I'm wondering if it's the AirPods. So I'll let you troubleshoot that, and I will introduce Dr. Lisa Savage.
Hi, everybody. So happy to be here. I'm Lisa Savage, and I am based in Austin, Texas, where I was in private practice for 25 years. I trained long enough ago that menopause management was part of my training. And so I did it from the very beginning of my residency all the way through many years of private practice. And it was part of my practice that I really enjoyed, because I can make such a difference for women, not only with their symptoms, but also their long-term health. And so when I closed that practice and soon after found Genève, focused on menopause, I knew that I had come to the right place. My fun fact is that I have at all times during my appointments a canine medical assistant named Tucker, and he's very empathetic. He's always with me at my appointments, and I got him through a group that I have volunteered with for probably 30 years, and it's the Gold Ribbon Rescue Group. We rescue, rehabilitate, and rehome golden retrievers in Central Texas. Another quick fun fact is that Tucker is not a golden retriever. And I've had 3 dogs from the group, none of which had any golden retriever in them, but they all looked the part. So I'm glad to be here and excited to get going.
Excellent. Thank you both for telling us about that. And thank you for Tucker for assisting in this webinar
Yes, he's
today.
Here.
Yeah. So I wanted to start because we're doing this webinar in honor of Menopause Awareness Month. And I want us to talk a little bit about why it's important to have a Menopause Awareness Month. Like, does it matter? and what does it do for women around the country and around the world? And I'm going to pick on Lisa first.
So, menopause is having a moment, which is great. Back when I trained, it was very integral to training, and doctors were well versed in it and prepared to help women. And then over the years, there was a big study in 2001 that kind of put the kibosh on menopause management, not only for patients, but for doctors, which was a real shame. And fortunately now, the pendulum is coming back, and menopause seems to be something women are talking about, employers are talking about, physicians are talking about it. We find clinicians who are so eager to get more education, to be able to help their patients. And the thing is, the reason it's so important is that given our lifespan, we're going to spend half of our life in perimenopause or menopause. And so we want that second half to be vital and fulfilling. We want to be able to do all of our roles, whether it's parenthood or being an employee, our athletics like snowboarding, whatever it is, we want to be able to continue to do those things in good health and with good confidence for many years. So that is my feeling about, menopause having a moment, and also how important it is and how exciting it is to be now at a time when it's really getting the notice that it needs.
That's a great answer. And, I always, for people who've never met me, I'm a bit of a data nerd, so love me some numbers. And, when we went to the Menopause Society meeting, all three of us were there. They were talking a little bit about how few women actually are getting menopause hormone therapy. So that's not the only treatment for menopause, and certainly not, the only thing we do for menopause, but it's a marker for what women are being heard and treated. And, they were saying that it really hasn't risen all that much, at least in the time frame of the study, and it's only about 1.8% of women in this age range. But what we have also seen is data coming out that says that women are getting the diagnosis of menopause now. So that's climbed rapidly between 2018 and 2022. Dr. Dooley, is that your experience?
Oh, definitely. I think that people are now getting the diagnosis that we've always known has been there, but we haven't actually been saying it, or people felt uncomfortable because they didn't want to give a diagnosis and not know what to help people with. So like, if I say it, now they're going to want me to fix it. And if I can't fix it, that's awkward.
Yeah.
So yeah,
Very
I
true.
think it's good to know now that we've come full circle.
Mm-hmm. And I totally agree with that. I think there was a shying away, like in that time period, especially right after the Women's Health Initiative was released in 2001, 2002, when people didn't know what to do to replace the hormones that so many women were on. We just sort of ran from the diagnosis and ran from the symptoms and stopped talking about menopause. And that's why I think it's so important that we have an awareness month, because there's a whole generation whose mothers got no care for this and who don't really know how to talk about it. And now if we stand on rooftops and shout about menopause, maybe we can make it better for the next generation of women as we come up through this time period. Yashika, you talked a little bit about having treated perimenopausal and menopausal women throughout your career. But what really brought you to Geneva and like the fundamental care of menopausal and perimenopausal women?
I think the fact that there was such a gap. I mean, you would go some places and there were people that were talking about menopause, and then there were other places where it was almost like a menopausal desert. People would be like, I've never heard of that. That exists? What do you mean there's care? And I think what I really loved was that Geneva was like stepping forward at a time when nobody was stepping forward online and really trying to get the information out there, really trying to go directly to the patient and saying, hey, your doctor may not be talking about it. You might not have heard about this, but we understand. We hear you. You're having these symptoms. They're real. They're not in your head. And this is a place where you can come. We can actually talk to you about those symptoms, acknowledge them, and tell you and give you a way forward, which when you all started, there was nobody doing that, right? And so I think I really loved the fact that there was somebody willing to step out and help women when there was no help.
Yeah. And Dr. Savage has been with Genève and Genève Telemedicine pretty much since we started it. Yeah. We seem to connect at just the right time. And I know, Lisa, you talked about how you got good menopause training in residency, and then the WHI came along and we all stopped doing hormone therapy. Did you find, like me, that even though I got some fundamental training, since we had stopped doing hormone therapy, like there was just this huge time in the middle of my career where nobody wanted it, everybody was afraid of it. We didn't really have great ways to describe why it was safe and effective. And so as my patients started to age into menopause with me, because I'm also menopausal, I had to learn it all over again. Did you have that same experience?
Well, not exactly, because I don't know if this is good or bad. I actually kind of didn't believe the WHI conclusions at the time. I was a super skeptic because managing menopause was something that I had always done, and I felt like I had a good understanding of it, the risks, the benefits. And when the WHI came out, I gave it the side eye. I'm like, I don't know about that. I mean, but my office phones were ringing off the hook. Patients were really freaking out. They were stopping their therapy. And, it's a real dilemma because on the one hand, I felt like I had a pretty good basis for why I thought it was a good idea for a lot of women. And on the other hand, there was this hysteria in the media and people were confused. Patients did shy away from it, but man, the ones who did come in very symptomatic or really wanting to be on it, regardless of all the negativity that was out there, I just continued to do it. But I did find myself saying things like, we're going to use the lowest dose for the shortest period of time, which we don't do anymore. We've lifted a lot of those sort of boundaries around it. But I did sort of modify my counseling some, but I will say that I never abandoned it. I never did. And I think that that's just a function of having trained in the late 80s, early 90s. I'm dating myself. But yeah, I felt like, there was something didn't ring quite true or right about the WHI. So I never really embraced it.
Yeah, well, that's wonderful. And I think, I had a similar experience. I was training at the time it came out. I was finishing my training, and I was training in a place that did a lot of menopause care and had menopause expert physicians on staff. And I remember being in my resident clinic, and the press release happened for this study, which should never precede a study, but somehow this time it did. And I just remember my attending at the time, who was one of our menopause experts, going, "This is bull tookie." And telling us all why it was bull tookie, but it didn't stop women from coming off their medication and not wanting to talk about it. And, it was I think it was a really hard time for a lot of women because you guys can chime in. In my experience, for the right patient, hormone therapy can be life-changing. It really does. I think a lot of people come to us with the idea that they don't need it. They're not going to die of menopause. There's no reason to, like, it's not going to kill them. So why do I need this? And I think one of the best things that we get to do every day at Genève is say that your quality of life matters and is important. And we get to talk about your quality of life and treat to an excellent quality of life. Do you guys have the same experience?
I do. Becca, I quote you all the time, and I tell patients and everybody who will listen that menopause is the only endocrine failure where patients are told to just gut it out. And if we look at it that way, it's an endocrine failure. And we don't tell people with hypothyroidism that, it's going to be okay or your quality of life is negatively affected or you feel awful, but it's all right. We don't do that. And so no, I'm so glad that we are validating patients' experience and offering them something that can help.
Yeah. The other thing I like to say to patients, which I'm sure both of you have heard before, is that nobody is waiting at the finish line of menopause with a blue ribbon for you because you didn't use any hormones.
Yeah.
Nobody cares.
There's no award for suffering. Yeah.
No. Although I feel like as women in the society, we get told that we are supposed to suffer in a lot of ways, but it's not true. We don't have to. Um, Ishika, what's one thing that women tell you is a huge impact on their quality of life in menopause, and how do you help them address it? Like, what's one of the symptoms that really you're hearing every day?
I would say just feeling not like themselves, like to the point where they go to work and they are just like, they're like, I'm walking in a fog. I am usually on top of things. I can answer questions. I know I can handle this job. But now they're just like, I just feel so lost. I can't get the words. It's just, and everybody around me notices it, or I feel like everybody's looking at me and notices it. And that kind of amplifies the entire issue. And they're just like, I feel so isolated and alone because I can't tell anybody what's going on. And it's almost kind of like they're like, I feel like I'm going crazy. It's like I kind of know that I'm not, but it's like it's this crazy place to be and nobody's talking about it. And I think that for a lot of people is just very, very hard.
Yeah, no, I agree. And having been through it myself, I can definitely sympathize. Spent a couple years really not feeling like myself. How about you, Dr. Savage, Lisa? What's something that you're hearing every day?
Sleep, sleep, and sleep. Yeah, I always emphasize it's really the cornerstone of feeling better, because there's so many downstream symptoms that come from disrupted sleep, whether it's brain fog or mood change or body aches or joint pain, low energy. If you look at the common denominator for all of that, it's poor quality sleep. And menopause can affect sleep in two ways. One is direct and one is indirect. There are the night sweats or warm waves or, nighttime heat episodes that will wake us up. But also estrogen deficiency impacts the architecture of sleep. You've heard of the stages of sleep like deep sleep and REM sleep. The sleep architecture can get disrupted. And so when it is poor quality for direct and indirect reasons, it can have such a huge impact, not only on the way a woman feels, but also on her long-term health, because we know that chronic sleep deficiency can be a risk factor for a lot of long-term issues, including cardiovascular disease. So I always focus on sleep and how can we optimize it.
Yeah, that's a really great point, because I think we undervalue sleep in our culture. We value the go, go, go. I can operate on 4 hours of sleep, but you can't actually long term operate on 4 hours of sleep. You need a good solid 7 hours. I think the one that came to mind for me was mood disorders and mood disturbances. And they can be different in different parts of the menopause. When I talk to perimenopausal women, so women in their 40s probably, who are maybe still cycling regularly or starting to get irregular, anxiety seems to pop up. And it's unexpected. Some people already have some level of anxiety and it can get much worse. But I'm seeing a lot of anxiety pop up in women who've never experienced it, or at least never recognized it in themselves. And it can take unusual forms. I had a couple of patients who couldn't drive over bridges. Just suddenly that was terribly frightening. And we live in Seattle. We have bridges everywhere. You can't go anywhere without driving over a bridge. Or it can be the anxiety that in the middle of the night, when you're trying to get some sleep, you wake up at 2 o'clock in the morning and suddenly the list of things that could go wrong, or the to-do list or whatever, is rolling through your head and you can't get back to sleep. So that's one thing. But then depression, especially in the postmenopausal time, can bump. And, I think we don't realize how many estrogen receptors and progesterone receptors exist in our brains. And we don't think a lot about how estrogen works within the serotonin system and progesterone works within the dopamine system in our brains. So when you switch how much of that you're making, you're going to sense it. And it can be really disturbing over the course of that transition. The good news is it tends to even out over time. The bad news is perimenopause is actually one of the highest risk times for suicide for women. So we cannot afford to ignore it. Going to switch gears a little. So all of us at Genève do the full pantheon of menopause care and perimenopausal care. But what's one area, I'm going to start with you, Lisa, where you really have a special interest? What's something about menopause or menopause care that you love to talk about and you write stuff for us about or do webinars on?
Sex.
Sex.
Sex. Yeah, I feel like talk about not being talked about. And women and couples suffer in silence. They're hesitant to bring it up. They're embarrassed. They don't think anything can be done. But women who go through a menopause transition will have genital effects. So estrogen deficiency will lead to thin, dry, fragile, poorly responsive, poorly arousable tissue. And almost everybody is a candidate for some kind of therapy that's going to help that. The problem with those changes, we call it genitourinary syndrome of menopause, or GSM. It will be progressive. That means it gets worse and worse and worse over time. So we can, if we intervene early enough, we can prevent that from happening, or we can also rescue it if it's already happening. And I always say, we're going to rehabilitate your vagina because discomfort or pain with sex is the number one killer of libido. And how often do we have our patients come in and complaining about low libido, no libido, my sex drive is gone, where did it go? If we start with tissue quality and remedy that, and then we can talk about the other elements of libido, which there are several. It's multifactorial for women. But I love talking about how to remedy any pain or discomfort. And then I love talking about the difference between spontaneous desire and receptive desire. I feel like that phrase is sort of my middle name, because spontaneous desire is something that we have in our earlier years, and it just descends upon you. It's just there. But if you look at it, it happens in ovulatory cycles when a woman is reproductively capable. I call it Mother Nature's call to reproduce. That's spontaneous desire. You don't have to work for it. It just is a gift. Here it is, right? But then across the menopause transition, when ovulatory cycles are waning, a different type of desire will predominate. And actually, for some women, probably a lot of women, receptive desire has always been there for them. It's been their primary form of desire. And what it means is that instead of descending upon you, it comes after arousal. So arousal comes before receptive desire. You need arousal to conjure up receptive desire. And I always say that desire may not lead you into the bedroom, but it can very well follow you there if you let it, if you're aware of that shift. I always encourage patients and their partners to embrace receptive desire, learn about it, cultivate it. And when people understand that, they understand they're normal, there's nothing wrong with them, and they understand how they can make their intimate life a priority and make it satisfying. It's so satisfying, pun intended.
I think we probably just end the webinar there. Yashika, I'm going to pose you the same question. What's one area of menopause or perimenopause that you really like to focus on or like to talk about?
For me, I really like to talk to women about their lifestyle, their weight, and how they feel in their bodies. I think this comes up over and over again, and just really talking to women about how our body composition has shifted and what does that look like and how I can still be healthy. And, I think a lot of women throughout their life, like we talk a lot about diets and all of that with our friends, but there's something about in the perimenopausal and the menopausal period that all the prior things that we did before, we could go on all those juice fasts and cleanses, and they used to work kind of, sort of, and now everybody's like, it doesn't budge. And I think when you hit that point where it's like, it doesn't budge and you feel so frustrated, and a lot of women start to then blame it on themselves, like, what am I doing wrong? I tried this and I tried that. And for me, it's really being able to have those conversations with them and being like, it's not just you, right? It really is. Things have changed. And I think because women are told, and because on social media, they're like, do this exercise or try this thing or take this thing, or if you would do this or have this shot or pill or whatever, it would all be cleared up. I think a lot of women continue to blame themselves and say, I haven't done it right. And it's really being able to have that conversation and like really breaking it down and being like, no, sometimes there are just other things going on, and really explaining that to them so that they don't continue to beat up on themselves and be like, I have to try harder or do more, and reaching for this I don't know, sometimes it's like this unattainable thing. We're all kind of thinking, if I could have those 15 pounds off and kind of look the way that I looked 15 years ago, but really starting to have those real conversations about like resetting expectations and what do we really want to look like? How do we want to feel? What do we want those next 30 years to look and feel like? And how do we want to feel in our body and be healthy in a new way that isn't always portrayed for women our age?
It's definitely not portrayed in social media or the media. And along those lines, I have a lot of people who talk to me, well, we see all these celebrities who look exactly the same as when they were 20. And I say they have a personal chef and a personal trainer and a personal plastic surgeon. And if you get those three things, you will also still look like you're 20 in some fashion.
I don't
But
want
most
to
of
look
us
like
can't
I'm
afford
20 though.
Huh?
I said we should embrace looking the way we are at every
Right.
age, right? We have to redefine beauty standards.
Mm-hmm. And I totally agree with you there. I think that's actually one of our guiding principles at Genève is to look forward and to live forward. Because I don't know about all of the people on this call, and maybe I was thinner and I had firmer skin when I was 20 and probably had a lot more blonde in my hair rather than gray. But I'm much happier and more capable and more interesting now in my 50s than I ever was in my 20s. And I am very happy to be at this point in my life. I think for me, there are two areas I really like to think about in menopause. One is perimenopause. It's an area of fascination for me. We've very poorly studied the menopausal transition. I think we've dismissed women in the menopausal transition for generations and told them, oh, you're still having periods, nothing's wrong with you, it's all in your head, which is not true. And I love talking to women about why it's really hard to diagnose the perimenopause because we don't have lab tests for that. But that if they're symptomatic, then we need to listen to them and help them manage those symptoms. I think the other area where I really like to focus is longevity, and not in the sense that I'm going to sell you something that's going to make you live longer, but what are the fundamental things we can start thinking about in perimenopause in terms of our lifestyle and our health that will help us to live a really healthy second half of our lives? How do we start to nourish our bodies to protect our cardiovascular system and our bones and our brains? And what other things do we do to nourish our brains over the course of the second half of life in terms of community and activities and being vital? So those are sort of my two big areas of interest. I think we've gotten pretty far along. I can tell from the little red dots on my team, Tyler, that we have some questions pending. So do you want to serve us up some questions and let us answer for the audience?
Of course, absolutely. Yeah, we've had quite a few questions come through during the duration of your talk. I just wanted to say as well, thank you to the three of you. I know that this style of webinar was conversational, but the three of you made it feel like we were in the room with you, having an insightful conversation, just the educational part, but just the empathetic part of it as well. That's what makes the three of you just the best. Just appreciate you taking some time.
It doesn't hurt that we actually like each other in person, so we're
always
happy to have a long conversation.
I'm sure it doesn't. I'm glad to hear that. That's very sweet. I wanted to kind of go through some of the comments thus far. I know you had seen some of the questions come through, but at the very beginning of the webinar, we had posed the question of how would you describe your menopause journey up until today? And we got a lot of, my journey has not gone well. Another individual said, every day I shake my head, it's a roller coaster to, I'm not the person I was before it. And I just wanted to, before we kind of go into the question standpoint, like how would the three of you encourage maybe someone who is currently struggling, or maybe has come to the webinar just without answers and just lots of questions? Like, how would the three of you handle encouraging someone in that particular phase of life?
I think that's a great question, Tyler. And when I meet with patients on Genève and talk to them face to face, the first thing I ask is, where are they in their menopausal journey and what are they feeling? And validate it, because everybody's journey is valid and everybody's symptoms are different. If you look on any website, you'll hear there are anywhere between 30 and 50 symptoms of menopause. all of it's real. It's not just in our heads. And for any woman that I get to meet in a medical setting, we come to an agreement about what the best course forward for her is. And everybody needs a slightly different thing. You know, we prescribe a lot of hormone therapy. We prescribe a lot of non-hormone therapy. We prescribe a lot of lifestyle therapy. But all of those things work together in conjunction to make you feel good again. And that's really our ultimate goal. You know, we're not aiming for a lab value. We're not, you know, it's different from other endocrine disorders in that, you know, Dr. Savage mentioned the thyroid. You know, we titrate thyroid to a number because we kind of have a good idea of where in that range you're going to be healthy and your body is going to function well. But for menopause, the thing we're titrating to is your symptoms, because that's what's telling us that you're not feeling healthy and you're not functioning well. And, you know, we get asked the question all the time, why don't you do lab tests? It's because the normal range of estrogen when we were cycling, you know, it went anywhere from 12 to 500. And we could feel good in any of those ranges. We just don't know where each woman's going to feel good. So what we're titrating to is your well-being.
That's fantastic. Thank you. Dr. Savage or Dr. Dooley, did you have anything to add or?
Yeah, I always tell women that it is a process. And I think part of what can be frustrating is patients come to the doctor and they want an answer. And I myself am a patient at times. So I totally understand. I want to come to the doctor. I want you to fix it. I want you to make it better. And I want to be done with that problem and not have to keep going back. And I think especially for women that are in perimenopause, I tell them that it's a process because things are going to continue to change. So when we talk that first time, you are at a certain point, you're having certain symptoms. And so we are going to try to, you know, help you alleviate the symptoms and feel good in your body. But what feels good at one point in time, 6 months from now, 3 months from now, 9 months from now is going to change because your body is continuing to evolve. And so I think that part is frustrating for people because they're like, you gave me this medication, I took this patch, I was doing really, really well, and then all of a sudden it stopped working. And that's the conversation that I then have to talk about. Like, it's not necessarily that it stopped working, but as your body is changing, as your levels of endogenous hormones have changed and you have more symptoms or whatever, now we need to kind of reevaluate what you feel like and how we need to change what we're doing to get you the symptom resolution that you desire. And I think having that conversation and letting my patients know it's not a one and done, and we're going to have to continue to work together as a team. And as your symptoms change and as you feel differently, we're going to have to tailor what we do. And so that, I think, resetting the expectation of what this is going to look like, what the conversation is going to look like, will help people not feel so frustrated.
That's a great point. I often tell my patients, I don't like to call it trial and error, but I call it try and try again. We keep working on it until we get it right. Lisa?
I so agree with what Shika said about the changing nature of this transition. It takes months to years, really years to completely traverse it. And it is dynamic. I use that word all the time with my patients, dynamic. It's going to be changing. We'll have to dial it in. We'll have to change it. At a certain point, you'll get to some stability, but especially in perimenopause, things are chaotic for a while and they're changing. And I use the word trial and error. I think I like try and try again better. I'm going to start using that. But what I would say to anybody who's feeling frustrated, ill-informed, not well taken care of, come see us. Come see one of our Geneva physicians. We're licensed across all 50 states. We have a great team of like over 30 doctors. But there are also other physicians, maybe in your community. The Menopause Society has by zip code physicians who are better prepared and trained to help. So I always just say there is help available. And if you are having symptoms or you just want more information, you want to get something that is reliable and accurate, Genev.com, we have a lot of free resources, articles and blogs and so forth. And so, take advantage of our medical expertise, take advantage of our library of resources. We also integrate our care with a great team of registered dietitian nutritionists. We probably want to talk about that a little bit more, because those lifestyle modifications and that wraparound care with our RDNs is so important. So I just want to say there's hope. And if you need help, well, it's available.
That's a great point. And I'm glad you brought up our team of registered dietitian nutritionists. I think they're fundamental to the care we provide. And I always tell people, oftentimes I'll recommend working with them. They're like, well, I don't really need to lose weight, or I know how to lose weight. I'm like, it's not about losing weight. It's actually about learning how to nourish your body for the second half of life. But they're also all very skilled in talking about exercise and movement and sleep and meditation and wellness. So they can be a huge help and a big guide on the journey through the perimenopause and the menopause. So I'm really glad you brought them up. What questions have you got for us, Tyler?
Yes, absolutely. As a quick plug, I did go ahead and input in the chat our sign-up link to get seen by one of our clinicians. It's just our genev.com sign-up URL. I know that all three of our clinicians here had kind of made the plug there. Now, one thing I had heard as far as an answer from the three of you was just the insightful listening skills that the three of you have. Oftentimes I feel like our patients overwhelmingly respond with, I just feel heard for the first time. And I think all three of you would identify with hearing that answer. And again, just appreciate the level of insight you bring. Here was one question, and it was kind of inputted in the chat when you were talking about HRT, Dr. Dunsmore Sue. This particular individual had asked the question, I've heard that there is a window for HRT, and if you are outside that window, as in past the window, then you cannot go on HRT. Is there any type of clarification that you could maybe provide around the time frame, or if it might be a specific answer for this individual, we kind of explore maybe that as well?
Well, we can talk about what we know from the data and about the safety of hormone replacement therapy. And yes, there is a window. I like to call it a window of opportunity. It doesn't have a lock on it. We are physicians, we can prescribe at our discretion. But we like to think about the window of opportunity of when is HRT going to be the most beneficial, and how does that taper off over time? And whenever we're talking about hormone replacement therapy, we're thinking of both benefits for the patient and risks to the patient. And what happens over time is that the benefits come down and the risks go up. And there just sort of comes this point where a tipping point's been reached, and adding hormone replacement therapy is no longer going to be the helpful thing that we think it is. Doesn't mean we don't ever do it. Sometimes someone might be just outside that ideal window, but they have significant and severe symptoms that are best treated with HRT. And then we discuss the risks and decide that it's worthwhile to start it. In terms of what those windows are, I break it down into sort of three groups. There's the 0 to 5s. So 0 to 5 years from your last period, or when you had your ovaries removed, or if you don't have periods because of Mirena, when you started to have symptoms. So that first 5 years is the ideal window. So this is the window in which, if there's cardiovascular benefit, you're going to get that, where the risks are actually quite low because you're typically on the younger side. So like the clotting risk is actually quite low. And where, in any of the windows, you get the bone benefit of HRT. HRT is always and forever good for your bones. And then there's sort of the 5 to 10 year window. And in that window, it's probably a little more neutral. The risks haven't gotten that high yet, but you may have lost some of the benefit of that early start and getting some of the health benefits, but you can still start it for symptoms and it may still be beneficial. And again, like I said, still good for your bones, although you may have lost some bone by that point. It's really about 10 or more years out that we start to see the risks really outweigh the benefits. And the big risk there is cardiovascular risk. So understanding that estrogen, it slightly increases the chance of clotting your blood. And that's more true with something that you take it in pill form, less true if you put it on your skin. But still, we have to think about that risk, because once you've gotten 10 years into menopause, our cardiovascular system has changed. It's not as flexible. We start to see fat and plaque build up in our vessels, our arteries, and our veins. And so when you add something that clots your blood, at that point, you can build clots on those plaques. And that's what leads to heart attacks and strokes. So we know that around 10 years and higher, we start to increase the risk of heart attack and stroke if we start HRT. Now, if it's been 11 years and your hot flashes are terrible and you have a very low cardiovascular risk at baseline, we might still start. But if you already have cardiovascular disease and you're thinking that you want to use it for something like longevity or, to make your skin look better, then it isn't worth the risk. So that's how we're making that calculation.
Understood. Thank you. There was actually some additional questions that kind of came through as well related to HRT. I'll probably ask one more of those and then kind of pivot to an additional topic, just so we can cover a little bit more wide ranging. But this individual had asked, how do you know you're the right patient for HRT?
I'm throwing that one to Lisa.
So your physician will evaluate your candidacy for HRT. And when we do that, we look at your personal medical history. We consider your family history. We take into account your current symptoms, your current risk profile, and then we come up with a determination about whether you're a good candidate or not. And most people are, the benefits will outweigh those risks. There are some patients who are simply not a candidate for it because the risks outweigh the benefits. It's that ratio that Rebecca was talking about. And certain categories of patients can't take it. For example, history of breast cancer, personal history of breast cancer, personal history of blood clots. And so we won't prescribe it to somebody who's for whom it is not a good idea. But the determination comes in that one-on-one visit when we can have the context of your personal medical history and everything that we ask about. And so that is how you meet with a physician who can go over it with you and decide together, one, whether you're a candidate, and then two, would you like to do that?
Perfect. Thank you, Dr. Savage. There were a few additional questions around HRT, and I know they were coming in fairly frequently here in the Q&A section. I just wanted to give a disclaimer. We won't be able to get to all questions, and so I apologize if we didn't answer your specific one. But again, here's a plug. Go to genev.com and sign up to see one of our clinicians so that you can ask your question specific to you and get a specific answer back. I feel like that would be incredibly more impactful for you as I'm kind of looking through some of these right now. I did want to pivot us away from HRT in that particular conversation because this individual had asked a question relative to lifestyle support. And you kind of mentioned, Dr. Dunsmore Sue, and Dr. Dooley, Dr. Savage, you have as well, around our registered dietitians. And I'd love to hear, if you could provide a little bit more insight on like the registered dietitians and their conversations around weight gain and healthy lifestyle choices, and just a way to kind of partner that with maybe the conversations they'd be having with the three of you on their menopause journey.
Yeah, I'm going to start and then I'm going to throw it to Yashika, who also works a lot in this space. In terms of how do our registered dietitians work with our patients, really their goal is to work with women on their goals. So a lot of the first couple of visits is really about setting goals and understanding why someone is there. It really helps that because there's no one right answer to the changing body in menopause. I mean, we all aim for healthy, and everything we do, everything they do is focused on healthy longevity. But, for some women, that may be one body weight, and for other women, that's going to be a different body weight, and you can absolutely be healthy at any size. But for some women, maybe they're not comfortable at the size they are in. They can't exercise as well as they want to, and then they might work on weight loss. It's a very individualized process. What can you add, Shika?
I think the other thing that they really start talking about is if you are trying to tone, or I see somebody talking about like the extra 15 pounds, and if you're trying to be healthier? What should I do? Especially if my body has changed or I have aches or pains, or there are certain things that I used to be able to do. Like, some people are like, I used to really enjoy running, but now that hurts my hips or certain joints, right? It's about what are the things that we can have you do that you still enjoy, but that really still give you the benefit, both for your muscles, your joints, and your bones. And especially for women that are in particular trying to lose weight, and maybe in the past, you really enjoyed, I don't know, running or cycling or whatever. And people are like, I'm doing those things and I'm doing it, an hour a day and nothing is changing. It's really talking about why that might not work when you go into the perimenopausal and postmenopausal period, and how now we really need to talk about, really toning and building muscle and strength, which is a totally different conversation than many women have ever had when talking about their body. And many women are concerned about bulking up, right? And it's like the conversation about what our bodies need at that point and how we can work for our bodies and get our bodies to really work for us changes. And it's like more education in that way, especially if those are not things that you traditionally did in the past. And I think the registered dietitians are really good at kind of explaining why you might want to consider shifting what you do and how what used to work before, why it doesn't work anymore. Because I think a lot of women get very frustrated when you continue to try to do the same thing over and over again, and you find that sometimes you're just hungrier, you're eating more, and you're putting on weight, and you're like, nothing works, right? And so having those conversations and having somebody who really has education and can really break it down to you is so helpful, especially when there's lots of miseducation on the internet that will kind of make it very confusing to figure out what is the right thing to do at this point in our lives.
One thing I hear our registered dietitians talk about a lot, especially when we're in meetings, is helping women discover sustainable change. And I think that's critical because you can go on the internet and find any number of menopause diets that are very restrictive, they're very low calorie, they might work for some period of time, but if you can't sustain that change, it's not going to work for you. So that's really their focus. They really look at what are you already doing and what are some small tweaks that we can institute that feel good in your regimen that you can continue to do long term.
I wanted to add just one thing because I saw somebody in the chat. I think it said something like, so do I just have to accept these 15 pounds? And I do preach a certain level of acceptance of a new normal, because I think that for a lot of us, we could do those restrictive diets. We could exercise until we're blue in the face and passed out. We could expend all kinds of energy that is better used in other more noble pursuits in trying to get back to what used to be. And I say it's like my gray hair. My hair will never not be gray again. I'm never going to go back to a point at which it was not gray. It's not possible. But I still take care of it, and I still try to help it be healthy. And I think it's the same with body and weight and body composition, is that you want to be healthy in what is now, and you don't want to always be striving for what was. Like Rebecca said, we want to be forward looking, and some degree of acceptance around a new normal is really liberating. And I don't mean to ignore things where you feel uncomfortable or but insisting that you're always going to be the same size or you're always going to be the same weight, I think is futile. And so I like to give a lot of permission and a lot of validation and sort of cultivating acceptance and then being the best you can be with what is now.
That's a great point, Lisa. Thank you for that.
Thank you to the three of you. So we have about 5 minutes of our webinar left. What I wanted to do is ask one more question of the three of you. But before I did, I wanted to input into the chat our last poll question for the day. And if you've attended one of our webinars in the past, this question is going to look and feel familiar because we ask it every single time we have one of these. But for us, it's just insightful. And it's a way that we gather information on how to improve our webinars in the future. And we also, at the end of it, we just want to make sure you feel heard. And so I'm launching that now. And really, it's just for us to capture how you're feeling, if you feel more knowledgeable about menopause as a talking point after attending today's session. So I've put that in the chat. Take some time to fill it out. And while you're doing that, I wanted to ask one question that I'd love to hear kind of a response from the three of you, because I feel like this question does kind of correlate and kind of reach across all of the questions that kind of came through. And it's as simple as this. For those that are attending, and for those that might have a symptom that they are struggling to, deal with on a daily basis, or I saw some of the comments come in talking through, they feel a particular way and they don't feel like they can get out of feeling that particular way, and dealing with family or dealing with family misunderstanding this current phase of life that they're in. How would you encourage someone in their own menopause journey to have a conversation with their family so that they could be more understanding, as we are sitting in World Menopause Month, wanting to bring awareness to this talking point? How would you encourage those listening to say or bring up this particular topic so it no longer feels taboo?
It's hard. It's almost hard for me to answer that, Tyler, because I spend so much of my life talking about menopause that I can't imagine it being taboo, but I do know that happens. Sorry, you should not sit around my dinner table. This is all we talk about. What do I encourage women to do? I encourage them to make sure they find someone who hears them. You have choice. And when you go to a medical professional or a physician, if they dismiss your concerns, go somewhere else. It may be that you find out that they weren't meaning to be dismissive, that you have a reason you can't have HRT, or, there may be something behind that, but you need to be comfortable in the conversations you're having, and you need to be heard. And, that's why we stood up Genève, because we knew that there are large parts of the country where there just aren't medical professionals who understand menopause and can hear what you're going through. It may not be that you get exactly what you thought you needed when you came in, but someone will listen to you and hear you and help you to understand what the best course of action is.
I think one of the biggest things you can do is just let people around you know what's going on. I think so often a lot of women try to hide it, and you're having a hot flash or you're having a little bit of brain fog, and you're trying to compensate, and it's almost like you're overcompensating. I don't want to tell people why I'm turning red. I don't want to tell people why I'm hot and sweating. And sometimes just letting them know, I am so sorry, I'm having a hot flash. I need to take out a piece of paper. Give me a second, right? Or I tell my people all the time, if I'm trying to say something and all of a sudden I forget, I'm like, oh, give me 1 second, right? Or I'm like, I'm having a menopause moment. I need to think about that. I can't get the word. And so I just let them know what's going on. It's like, I am paying attention. I am here with you. I did hear your question, but all of a sudden I'm not thinking about whatever you asked me because I'm having a hot flash, or I'm so flustered, or the word just won't come, right? But I think that helps them to understand that I am tracking the conversation. I am paying attention. I'm not disconnected from my husband. It's just the fact that I'm having a hot flash, so I can't focus and have this conversation right now. Or I'm frustrated because I'm tired and I didn't get a good night's sleep. I think the more that you can let people know what's going on and why you're feeling the way that you're feeling, or why you might be short-tempered, or why you just don't seem quite right, lets them know it's not them, right? It's not that there's a problem with the relationship. It's not the fact that you are irritated about something they did. It's something that you're going through. And I just want you to know that I just need you to work with me as I try to figure it out for myself.
I'm going to add a Mr. Rogers saying, if it can be mentioned, it can be managed. And so, it won't be any secret to those in your household, but, bring them into the conversations you're having with your doctor, and give them reading materials. We should educate our families. And I love what Chica said about, examples in the workplace. And Genève has a focus sometimes on the workplace, menopause in the workplace, and how it affects our roles as employees and managers and CEOs. And so I think that, making it an open conversation and freely admitting, when you're having a hot flash, or needing a moment, or taking your cardigan off and on, just to say so, because I guarantee you that there will be other people in the room who can sympathize or empathize with that. So I think that open conversations are critical.
That's a great point. And I'm glad that you brought up the workplace specifically, because I think, I hear a lot from women that they don't feel as capable as they used to in the workplace. And I tell every woman who tells me that, you've always been overly capable. So even if you're working at 80%, you're probably still better than most of the other people in that room. So please give yourself a little grace. We will get through this.
I love it. Well, I'm going to come back on camera, send us all adieu. Again, I just wanted to thank the three of you, Dr. Savage, Dr. Dooley, and Dr. Dunsmore-Sue, for not only your time, but just the insightful conversation. I know I've already said it earlier in our webinar today, but it felt like we were all in the room together, and I just got to listen to the wisdom and the care that the three of you possess. So you three are a treasure, and I appreciate you three very, very much. Just as a reminder for those attending, today's webinar is recorded. I'll send that out via an email tomorrow. That'll be linked to our YouTube page, which is a fantastic resource hub. We have lots of recordings there on this particular topic to all kinds of others. So please check that out. Go to genev.com and speak with one of our clinicians or registered dietitians. And again, we appreciate your time. Have a good rest of your week.
Thank you, everyone.
Thanks, everybody.
Thank you all. Goodbye.